what's up, everybody? This is Maggie Reichard, and you are listening to Nursing Uncharted, the podcast that navigates uncharted territory in your nursing profession. Happy Memorial Day weekend. Memorial Day was yesterday, so I hope everybody had some time to recharge, or if you're like me and you had to work the weekend, I hope that most of your patients were out enjoying the sun and not coming in, and that staffing ratios were good over the weekend. Has anybody else noticed maybe a lull of patient census in the summer? Because I've noticed that before. Maybe it's just me coming from a surgical background, or maybe it being flu season, but I feel like there's less of a patient census in the summer and the holidays. But in any case, I hope you have a hamburger in the sun or in something sometime soon to celebrate Memorial Day, whenever you get to celebrate it, because we celebrate holidays whenever we can, right? We have a great episode today. It's a realm of nursing in a department that I've never worked, but it is so unbelievably crucial to the fabric of the hospital system, and that is the emergency room. And I know ER nurses to be some of the most robust, fast-paced people, and I'm just excited to delve into what their days are like. So here to shed some light on emergency room nursing is Raul Vera. Raul is a second career ER nurse whose journey into nursing began as an ER tech while working his way through his undergrad degree in biology. On his path to nursing, he ventured through pharmaceutical sales, into biotech sales, through medical device training, and finally into nursing. Raul now has an MSN and has worked as an ER nurse for 6 years. Raul has also been an avid attender of the National Teaching Institute Conference for Critical Care Nursing, or NTI, for the last few years, and he took it upon himself to create a Facebook group for solo travelers coming to the conference so that we could all come together and connect and enjoy the conference together. So that's where I met Raul recently, and we had some pretty great talks over the week. So I was super excited to have him come on and talk about our experience at NTI with me, as well as everything about ER nursing. So Raul, welcome to the show.
Maggie, thank you so much, and greetings to all of you that are listening. I appreciate that you're tuned in.
Yeah. It's so great to have you, and we had such a fun time at NTI.
Absolutely. I think it was probably one of the best NTIs that I've actually attended in the last 3 or 4 that I've been to. So.
And a lot of people said that, and a lot of people attributed it to you because you really brought us all together,
Yeah, I think I provided the venue, and I think it's something that was really necessary. Nobody wants to go to a conference and then end up sitting in their room alone and watch Netflix or whatever, right? Which was entirely my first NTI experience.
Yeah. This was the first time that I went to a conference by myself too. And I can obviously talk to people, but it is kind of jarring to have to initiate conversation over and over and over again if you're going solo. And so it was such a great idea for you to be like, let me just make a Facebook group and see who will show up. And people freaking showed up.
We certainly did. I think we had 80 people in the group, and we had 40 or so people kind of in through all 4 days that we were hanging out together. So
yeah,
I was very excited. I was very excited about that. So, and look forward for next year because we're going to be doing the same thing.
Yeah, Philadelphia. It's 2023 is in Philadelphia for NTI. Is it the same? Do they have dates out yet?
Actually, I don't really know, but it's usually around the same time, I think.
Yeah. It was a great conference. I've been to other conferences. I've been to a head and neck conference in the past, and a neuro conference, but this is my first critical care NTI. And so you said it was the best one that you've felt so far. How did it compare? In what way do you think?
I think, first of all, in the number of people that showed an interest. I initially used the forum that comes with the NTI dashboard for the first one. I think the very first one I went to, I didn't do it. The second one I did. And I got, I think, 12 people together, which was kind of nice. And, I kind of whittled down to 6. And then there was a group of 3 of us that would just hang out. which was kind of nice. And then, of course, I do the same thing for the Emergency Nurses Conference. And so, like you mentioned earlier, I think, it's hard going to these conferences and trying to initiate conversations with people that perhaps aren't really interested in having a conversation,
Mm-hmm.
or are perhaps just don't know how to have that conversation.
Yeah.
So,
Yeah. And I really appreciated the flexibility and freedom to do things on your own if you wanted to, but then you could meet up with people at the end of the day, or you could find somebody in a room and sit with them. Like a lot of times, like in the expo, when there's, hundreds of different like educational opportunities or like medical devices that you're interested in looking at, or like job opportunities, and you want to like venture off, the solo traveler group allowed me to do that, and I could just like bop around different places, but then then we could meet up for lunch. So
right. Well, the nice thing too is you could bump into other people from the group in the expo, right?
Yeah.
Or in a class, right? Or going to and from, and you had somebody to grab a cup of coffee with, or somebody to kind of share in that experience of the expo, or share in the experience of those presentations, which we really had some great presentations.
Yeah, definitely. So they had a theme. I guess they have a theme every year. And this theme this year was rooted in strength. And it was all about just, connecting us, empowering us. And after the last 2 years, because NTI hasn't been in person, this was the first one in 2 years, or 3 years, I guess. So just, having this time that we were all together of like thousands of us, they really used that as an opportunity to try and, merge us back together with like a conjoined, purpose.
Right.
So that was really nice.
I think it was something that was very very welcomed, and definitely much needed, especially after coming out of the last 2-3 years that we've had, and it was great to be in community with everybody, with just the conference as a whole, and of course that everybody that joined the solo traveler group as well. And, it made the conference for me. It really did.
It was very emotional. I mean, there were points where it was really, a lot of nurses are not good at like taking a beat and kind of reflecting, I think, because we compartmentalize things, like something hard. You're like, okay, this is hard. That's for later. I'm not going to deal with that now, but I think that there was a lot of, exchanging stories and experiences over the last 4 days. They really made a point to do that. And it brought up, those super sessions every day, I feel like we're very emotional. There were these super sessions, which are like 90 minutes of different keynote speakers. The president of AACN would come up and talk, or president-elect. And they were really motivating. There was one keynote speaker in particular. Her name is Jade Simmons, and she's a professional speaker. And she was truly, captivating and amazing. She uses her piano talent. She's a professional piano player. And she blended that in with a message of like empowerment and purpose, finding your passion, finding your power within your profession. She speaks to a bunch of different, she said, I think she speaks to lawyers too. And so NTI actually they published little articles every day about what's going on. And so they had a little blurb about her and her speech and quoted her in the article. So I wanted to share something that she said during the speech. She said, quote, "I don't call you nurses," she said. "I call you atmosphere shifters who are gifted with the ability to change the temperature of the room toward the direction of healing, clarity, possibility, peace. That means that by default, you are dispellers of sickness, chaos, confusion, and negativity. Your purpose gets to ride itself out in a vehicle called nursing."
Wow. Yeah. Wow.
She was just so amazing. I mean, the whole thing was just, it was like 45 minutes to an hour of that.
Yeah, with 4,000 or 3,500 nurses all packed into this room, and she certainly did. Certainly did. It empower us. I guess it's a good word for that. You know, and that quote that you just told us about. It's very true. Mm-hmm. You know, and by the same token, we also have the ability to shift it into the not so positive as well, right? And so. It's hard some days to kind of keep that positivity going and shifting that atmosphere towards the positive. And it doesn't matter if you're an ER nurse or an ICU nurse or a labor and delivery nurse or whatever, working in a clinic. It's true. We are atmosphere shifters. And I think that if we recognize that when we go to work every day, I think we could do a lot more towards improving our patients' outcomes, their experiences.
Yeah, that, and even like the experiences of like our coworkers and our colleagues at work. Like that's, I think of after that, speech that she did, I was thinking about the way that I can impact my patients in that way and change the temperature of the room. But I was also thinking about the way, I mean, we're all burned out. There was a period where it was like all negativity at work. And I was just thinking about the power that we have to change our environment at work, to change, to learn about the nurse that's working next to you, or to change their day. So there's so much that we can control. There. So
absolutely, I think part of that is not getting caught up in what we're doing, right? Because a lot of it is we have to do this, and that, and then we have, I don't know, depending on what state you're in, X amount of other patients that you have to deal with at the same time, right?
There's so much that we have to, yeah. I mean, and you guys in the ER, I feel like gets so bogged down with like different tasks and things too. I can't imagine. I can't wait to like get into what the ER is like. I've been floated down there and it was freaking chaos. The whole day was just absolute chaos. So
it tends sometimes to be that way, and that's unfortunate, right? Because chaos can create negative forces. That often, right? So
I think, I mean, most of that day though, where I was working at the time, I think that they had just opened up an ER and they were having growing pains, and I think growing pains is a whole other bear where you don't like policies and you're out of resources, and sometimes it just feels like a third world country where you're like, why isn't anybody like highlighting the problems that we have on this unit right now?
Right. Or how come I can't find a 3cc syringe?
Right? Or food.
Right.
or snacks. Right. Exactly. Or like just just wild. Well, before we stop talking about NTI, do you remember any like interesting topics from there that like stuck out to you?
I think that all of the topics are interesting, and like anything else, the presenters often can either make or break the presentation and the class, right? Whether you want to be invested in it or whether, in fact, you're actually learning anything. There were two, and I wish I had my phone in front of me because I would tell you which they were. One was, I think, vasoactive drips, and then the other was about oh my gosh, it's I don't remember, but you know what, I'll get back to you and maybe you can add it as notes, because amazing presenters. They
really
absolutely.
They do really make or break the conference, the presenters, the way they, like, I actually there was two talks kind of almost back to back. They were about analyzing EKGs further than your just normal knowledge.
And then the basic understanding,
Yeah,
yeah.
and I don't know why I went to two back to back, because the one was so dry and I was just falling asleep. And then I went to the next one and I was like, oh my God, this makes so much sense. It was about axis deviations for EKGs. And I never look at the axis themselves and like how I think it's V1 and V6 or V1 and AVF maybe. Now I can't remember, but you look at like the positive, like what direction it's going as opposed as in regards to like the ion, channels. And that will tell you if you have a like right axis deviation, left axis. And I was like, it was exactly what the other presenter was talking about. but like the way that she presented it, it just made so much more sense. So that was really interesting to me, because you can tell, different like cardiac abnormalities from that, different like VTAC or even like, heart failure and just different things going on there. So I had never even like taken that into account, when I see like a like negative, like a really negative drop deflection. I'm like, meh, I don't know. It looks like that's the QRS of that one,
or when they're flipped or
So it just made me really want to look at EKGs a lot more. And it says on the EKGs like right axis, left axis deviation, but I just like, run right through that.
Right. Yeah, absolutely.
Yeah.
Right.
So that one was a really interesting one. And then there was another one on the hazards of suctioning, which I thought was a really great topic. It just kind of shed light on the importance of not using full suction when you're suctioning a patient. And they had this visual interpretation of it where they had a ventilator hooked up to pig lungs. Did you see this one?
I did. I saw the pig lungs. I did see that.
They had these pig lungs and it was hooked up to a vent with an ET tube. And he showed us, the respiratory therapist doing the presentation, showed us what 5 seconds of full suction was and the amount of volume that it decreased. I mean, these lungs probably decreased by 2/3 of their expansion. Wow. And it took, and that was just for 5 seconds. And they took, a good another 5-10 seconds for it to like completely expand again. So if you're going down and like going in there for 5 seconds and then you go right back down again, I mean, you're making your patient desat and that you're decreasing that, lung capacity by so much. There was that. And then they also made a point about suctioning with the catheter going all the way down to like the very hub of the ET tube. I totally do that because I came from an acute care floor where we deep suctioned, there was fresh trachs and that's just, you're just trying to get all the gunk out of there. But if it's like on a, I mean, you're essentially suctioning like where the bronchus bifurcates. And so you're just getting to like, that bifurcation and you can cause like, that's why pink tinged sputum happens because like we're causing that trauma. So, that was just really, I was like, so they say to line up, there's like notches on the ET tube of like measurements and there's also measurements on the catheter itself. And if you line up those two, then you can figure out at what point the ET tube ends and you really only want to go until that part. You don't want to like push it all the way in. So that, I mean, that was like, I should have, and I just had no idea.
Well, if you think about it, where do we learn how to do all this stuff? We learn how to do all this stuff in nursing school, right? And what do are you suctioning a trach patient? No. Are you? It's on this mannequin, and And so you don't really learn the finer or the finer, what's the word I'm looking for, the finer points of how to suction, right? And then not until you suction your first patient, and then you still don't really know what you're doing.
And then, right? I mean, you learn from nursing school, but then you also learn from other nurses. So if it's in common practice, you know, I think that's what's so important about evidence-based practice, and even just going to these conferences is like learning, you know, what's like the most correct evidence-based, you know, practice that we should be following. That was another talk I went to talking about the most recent evidence on some type of nursing practices that we do, which was I felt personally there was, for that talk, it seemed common knowledge to me. I mean, the facilities that I've been into have been doing this, but there were some, I mean, there was a lot of people in that room where they weren't, but it was like changing peripheral IV catheters like every 4 days instead of just waiting for them to expire,
get soiled, and
or like leak, or, you know,
come out, or
they were saying that the evidence shows that it's better on all accounts, I think, to just change it when it's necessary. There was that. There was, I think, about suctioning. Now I can't remember.
I actually attended another session which was about anticoagulation and the different anticoagulants they use, when to use them. It was a great presentation. The speaker was great. The thing was 2 hours.
Wow.
And I didn't quite make it to 2 hours, but it's definitely something I'm going to go back and review once the sessions open up. And that's the other nice thing about NTI, is that you can go back and look at these sessions and look at other sessions that perhaps you didn't have a chance to get to, because you'll have 3 or 4 sessions that you want to go to, and they're all at the same time.
It is true. It's an overwhelming amount of material and information that you only have so many, you know, time slots to go to. So you're just like running from back and forth, like, oh, I got to go to this, but I got to go to this one.
Yeah, absolutely. But, you know, in speaking about conferences, I tend to tell my friends that I work with, hey, I'm going to a conference, and I keep trying to get one of my buddies to go to conference. And I don't know, people just don't tend to want to. I mean, obviously NTI, there was 3,000-4,000 people, but I mean, there could be more, right? I think a lot of my coworkers, either they have family, they have kids, or other responsibilities. But I think these conferences are an important way for us to stay ahead of what's going on, and to bring those practices back to our institutions.
Yeah, right? It really does. And, you know, something that I found out too in talking to people this past week was the kind of, you know, if you are interested in going to a conference, check with your facility on what they're able to do to, you know, provide a scholarship or fund that trip. Because there are some institutions, like, you know, that will reimburse you for educational opportunities. And there was one person that I was talking to that said, if you're not in school, if you're not using that reimbursement towards a tuition, you still have access to that reimbursement. And so you can use it for educational opportunities. So I thought that was a really cool idea. And also there was somebody else that there was a NTI scholarship. I think she just Googled NTI scholarship.
Yeah.
And
with a great resource.
And that came up, and she applied and she got it. So there are ways, you know, you don't have to pay, you know, $600 or $700 out of pocket. You know, if you like check in with your facilities and see what they can do, because also, I mean, if the hospitals have the budget for it, if your unit has the budget for it, it only benefits, only benefits your unit by coming back to these places.
Absolutely. Yeah, I agree with you 100%. And I think that these institutions, our employers, should be it should be more of a priority for them to send us as well, right? To these um, or even if it's the people that are doing the education, where they can come back and kind of pass that on to everybody else that's there, right? Um, I think it's great if you can get the funding, if you can get the scholarships. But quite honestly, I think that you can save up in a year what it's going to cost you to go to these conferences as well. So start saving your pennies, because NTI is absolutely amazing, as is the Emergency Nurses Conference. I don't want to leave them out. But both of these conferences are amazing. So save your pennies. It truly is an amazing experience just to be with people from all over the country, all over the world, really, because we do get foreign nurses that come to these conferences.
It's 100. It is beneficial. It's very beneficial. So if you can make it a priority, if you can save up, or if you can find another, financial assistance for it, go. For sure, go.
If you belong to your local AACN chapter, they can provide resources as well.
That's another way.
And I recommend that if you are interested, get hooked up with your AACN chapters or your ENA chapters. Some of them are active, some of them aren't, but there may be one in the city over that's active. So, and they provide resources for these conferences as well. So. But truly, you have to go to a conference, regardless of what your specialty is. It's an amazing experience. It really is.
After these last 3 years, it was just really good to connect with people and hear other people's stories, and just, understand that nobody is alone by any means in the type of stress and, like anxieties, depression that we all went through in the last few years, and the hardships. I mean, it was just so unifying to see and hear other people's experiences over the last, 2 years. So it was very needed, and I felt refreshed after the conference, for sure.
If I could add something, and not to kind of bring the tone of the conversation down, but depression among nurses, among healthcare providers is something that it's just it's constant, right? All that we're exposed to. And here locally, we've had 2 or 3 doctors that have ended their lives. There was another nurse that had ended his life at one of another institution, and that's hard to listen to, because these are basically our brothers and sisters, if you want to look at it that way. And if there's one thing I can say, is that that's never the answer. There's always somebody that's going to listen. There are numbers that you can call, talk to somebody. It's taking on that burden is not ours alone, right? We can share that with others, and taking your life is definitely not an answer to whatever it is that you have going on. Look to the people around you. There's organizations and such that can help you with anything that you might need. So
it's really, thank you for bringing that up. I mean, it's so hard to get out of that space, if that's like that mental space, if you're there. But you can always reach out. I mean, it may surprise you who you end up reaching out to and how they can touch you.
Absolutely. Absolutely. And it just really never is the answer, I think,
Well, no, it was a good place to, I mean, it's something that was ever present in the last few years that so many of us experience. I mean, even me, like I'm such like a positive, bubbly person. And I remember in COVID, like not wanting to get out of bed, because I'm like, what's the point? I'm just going to work and coming home and doing nothing. I have nothing else to, do, or there's nothing else to live for. I mean, there's just, it's such a powerful thing for somebody, for me to feel that way. And me, like, I'm always such a positive person. I just can't imagine people that had like underlying depression already and then having to go through all of that. And, you know, it's just such a profound thing that we all went through. And so it's like, you know, so much more of a dire situation that we all should get together and talk about it and heal and, you know.
Absolutely. And that's kind of getting back kind of the NTI. That's kind of the nice thing about it is, you know, we're coming, you know, there's 3,000,
something like that.
35 or 400,000 just in community and being together. And then of course the 80 of us that signed up and the 40 of us that kind of came together, that what an amazing experience, you know, to be able to talk to each other and share stories and ideas and it's what an amazing experience.
We want to take a quick break from this episode to talk about the industry leader in travel nurse staffing, American Mobile. Combining the largest network of facilities and providers in the country with top-level benefits like higher earning potential, premium health insurance, and 401k matching, American Mobile puts you in the driver's seat of your travel nursing career. Make sure to visit AmericanMobile.com today to discover a world of adventure with American Mobile. That's AmericanMobile.com, the first step towards your next travel nursing adventure. So tell me about your history with ER, like where you started, how you kind of circled back to the environment.
So I actually kind of followed my brother into a lot of the things that he was doing. And, you know, he was on a search and rescue team. So I followed him into a search and rescue team. He became in the EMT and I followed him into that. And then he went to work as an ER tech. And then, you know, so that's kind of where my interest in medicine and in healthcare and kind of blossomed. And so I remember there's a county hospital here that I really wanted to work at, which is the one that my brother was working at. And of course, never could find my way into that. So we had another hospital here that's now gone, but it was an amazing hospital. It served a very large underserved community, which is kind of on the east side of town. So I wanted to work there. So as part of a class in college, I had to do a volunteer experience. And I remember going and knocking on the door of the manager, and I said, "Hey, I need to do a volunteer experience because I come here and do it." And so that kind of just led to one thing, and then they hired me, and so I was there for 3 years, and then I went to work for another hospital here in just up the way, that another amazing hospital, and that kind of exposed me to a lot of different aspects of healthcare, and I'd see these people, these young ladies, these young guys coming in here all dressed in nice suits and nice shoes, and it's like, wow, that
like, who are they?
And so I started talking to them, and I had a job in pharmaceuticals before I even graduated from college, which was kind of nice.
So they were pharmaceutical reps?
They were pharmaceutical reps, yeah. Okay. So a lot has changed in pharmaceuticals, and, you know, there's always, you know, people sometimes have a negative attitude towards pharmaceutical companies, and but, you know, there's a purpose there, and that's kind of to bring medications out. And so so I did pharmaceutical sales, and that was amazing. Those checks coming in and being able to pay off debt, and then I got in there right as the entire industry started to change, and so I had to kind of look to go somewhere else. I ended up going to biotech, and that was fun. I worked for a big pharmaceutical company, which allowed me to travel, you know, back and forth to the East Coast, and that was fun. And, you know, you're always constantly looking to grow, and you're constantly looking to evolve as a person. And so then after I went to work for a medical device company. And so that was pretty fun. I got to travel all over the country for them, which was absolutely amazing. You know, you get to travel on somebody else's dime, and you get to see new parts of the country. So, and then that led me to an even bigger medical device company where I did training, and they sent me all over the world, and that was just an absolute experience. I was gone 75% of the time.
Wow.
And sometimes I'd wake up and not know if I was at home or in a hotel somewhere.
I've felt that before.
Which is really disconcerting, where it's pitch black and you're in a bedroom somewhere, and you're thinking to yourself, am I at home or am I in a hotel? Right. So,
Right.
but it unfortunately the economy turned in 2009, and like a
Mm.
bunch of other people, I lost my job.
Mm.
Um, so let me back up a little bit. While I was in school, I was thinking, oh, well, maybe I'll go to medical school and maybe be a doctor. And then yet here I'm working as an ER tech with these amazing nurses. And I'm like, wow, well, I could always do that. So I was kind of working towards both, I think, really.
Mm-hmm.
Um, after not being able to work for a couple of years, I said to myself, well, I got to do something, because the economy was starting to come back. And I said, well, you know what? I'm either going to go to medical school or I'm going to go to nursing school. It's going to be one of the two, right?
Mm-hmm.
So during that time, unfortunately, I lost my mom. And
Mm.
so
I'm
that
sorry.
kind of, that it kind of put me in a place where I really kind of needed to think inwardly about what I needed to do. And so I decided to go to nursing school, and I did an entry-level master's program, which for those of you, if you have a degree and you're trying to go to nursing school, I think that an entry level master's program is another viable option for you to think about.
Yeah.
There's always a question of time. Everybody wants to be a nurse before they go to nursing school, right? That's the thing. You're thinking about, oh my gosh, I have 2 more years, I have 1 more year, but those years go by fast. And
Yeah.
so whether it's a year, whether it's 2 years, you got to find what works for you. And entry
Mm-hmm.
level master's programs are definitely a good place for that.
Yeah.
And then so this here I am. I went to nursing school and graduated and then started working. Yeah.
And you've never done anything else but ER, right? In your
I've
in your
never done
nursing.
anything else, been in the ER, did pharmaceutical, did the whole medical pharmaceutical, and then
Right.
back into the ER.
Gotcha.
So, but that's been in healthcare for a very long time in
Yeah.
one way or another.
Yeah.
So,
Right. I'm sure that
I'm
gives you
in
a
great.
lot of different, I mean, there's so much experience there to pull from, from all of these like other aspects of healthcare.
Yeah, absolutely. I think being an ER tech and um, well, really kind of cemented my path into the ER as a
Mm,
nurse. I think one of the biggest things that we learn from in life is loss, right? And so having lost my dad at a really young age, and then my mom, you often see those people in your patients, right?
yeah.
And I think you and I maybe talked a little bit about this at the conference, and being able to be there with people that are in an intense amount of suffering, or being there when people are closing their lives, or when there's birth, right? I mean, what
Hmm.
an amazing experience, right? So I think a lot of that, and a lot of that emotion that goes into these new beginnings and these endings is part and parcel of why we're nurses, right? And
Yeah.
so yeah.
It's really an amazing um it's an amazing profession in that way. And you know, it's you are not always prepared for those situations, certainly not as a brand new nurse. I mean,
Absolutely.
like for me, when I started nursing, I was 21 and I was holding people's hands while they were dying, and it's like I just got a 401k. I don't know
Right.
how am I old enough and mature enough and experienced enough to like be a part of this person's, such a monumental part of their life, their
Right.
end of their life.
Yeah. Yeah.
And certainly, I mean, that's the case for anybody stepping into the nursing profession. You are, stepping into the worst part of somebody's life in the ER. Nobody wants to be in the
Right.
ER.
Well, it's either the worst part of their life or the best part of their life, right? It just depends on the situation
Yeah.
surrounding it, right? So,
Yeah.
but right, we're these random people that come into these lives to say, you know what, it's okay, you're not alone, right? And so, um, that for me was a special part of being an ER tech, because oftentimes it was just me sitting there with
Mm.
them holding their hands because there was nobody else,
Well,
and yeah.
what is this is just my not knowing, because I've never worked in the ER. What is the real difference between an ER tech and a nurse? Like what does the ER tech do that the nurse doesn't, or vice versa?
So ER techs are there to assist the department, and to assist the nurse, right? And so a lot of that what they're doing is, they're getting people back into the rooms, they're getting them set up on the monitors, they're taking them to and from, they're during codes, they're the ones that are doing the CPR, they're the ones that are sweating over the patient, they're the ones that are really kind of putting the effort in to really save these people's lives physically, right? And so they're a very valuable part of the team. They also take delegation from nurses as well. And so in some institutions they start IVs and they draw blood, and it just kind of depends on where and what institutions they are. But I've worked with some great techs, and they're a very valuable part of the team.
Okay. So they are very similar to ICU techs. I wasn't sure if there was a lot of difference there, because the ICU techs are also very important to the fabric of the unit itself and the department. So they're assisting the department as well as the nurse. So they're the ones stocking. They're the ones,
they do stocking
like
as well.
Helping, like with patients, being a part of codes, setting up the rooms, all of that. It's the same.
They are truly, I guess you can say an extension of a nurse, right? Because they get into with those patients that maybe need to be, helped up to go to the bathroom, or that need to be cleaned up. And, if I'm asking, for me, especially if I'm asking a tech to do something for me, I do my best to get in there and help them up with it. I don't want to just say, no, if I'm busy or if there's something else going on, it's kind of hard sometimes. But, nowadays everybody's so short-staffed, and we're just as short-staffed in techs as we are in nurses. And so, everybody's pulling on them, and they're great to have in the department. They're a valuable resource for sure.
Yeah. I remember there was this one time where I had a code, the patient it wasn't a code, but the patient, I think we had known, she was had slowly been deteriorating, and I think that she may have declared herself, but she had passed, and there was a lot of documentation and charting. I had a mountain of charting to do, and
as
there always is. And I was, I went over to the tech and I was like, hey, so-and-so passed, and do you mind helping me get them cleaned up? And he was like, oh yeah, absolutely. So I was, charting, but then I got up once he was in the room to help him. He's like, no, I got this. Don't go chart. Do what you need to do. And it was like, really? I mean, it was just really I had so many things, he just took that off my plate, all the postmortem stuff. And I was like, this saint. I can't ask anybody to do anything ever. I'm the worst delegator. I'm a terrible delegator. I just try to do everything myself. So it was truly an act of service for me, for him to be like, I got this, you go and chart.
That's somebody that kind of understands the what it is that you as a nurse do, right? And that you were kind enough to go back in there and offer to help them, because it's never something that one person does alone.
Oh, right? I mean, I just assumed, I just got up and went in there we're ready to do this together. Cause that's, exactly. It's a 2-person job, for sure. A lot of things are a 2-person job, but we ended up doing them by ourselves. But, but he was very, very gracious that way. So techs are super important. I just didn't know what the difference, if there was any, difference in ER techs versus ICU techs.
They're probably exactly
very
same.
Similar, yeah.
Exactly the same. In fact, I honestly think they need to have more responsibilities. I think they should be able to draw blood. I think they should be able to in some instances start IVs, and I think that giving them a little bit more responsibility and a little bit more hands-on kind of in the patient care side of things will really kind of round out and complement them and make them an even stronger member of the team, right?
There are certainly, but also give them more work to do.
Yeah.
There is some facilities that do allow, like I've worked as a travel nurse. I remember working at one facility and the techs would do all the lab work in the morning. That was like part of they would get vitals, they would draw the labs. So yeah, I think it is hospital specific, but a lot of things get put on the techs, I mean, especially techs that have to put the whole unit on their back and, they have to set up the rooms and stock the whole department and, just the stocking the whole department should be one person's job. But no, you have like, if you're short staffed and you have one or two techs for the whole unit, it's like, how do you manage, helping turn people?
That's a tough one. Yeah.
So yeah, I could see both. Well, that's both, like doing labs and like starting Foleys or starting IVs, how that could be, helpful, but also I think it would also just add to their plate.
Yeah, that's true. I think, it would add to their plate but I think it's something that perhaps they might feel a little more, what's the word? I don't know. I just think back to when I was a tech and wanting to start those IVs, wanting to put those Foleys in, maybe. Wanting to do a little more hands-on stuff. Yeah. So, instead of, hey, go turn this bed, or hey, can you go draw some blood, or,
that's true.
It'd be interesting to see how they felt about that, to see what they think about that.
Yeah. Yeah, that's very true. What about nurse-patient ratios in the ER? What's normal? Because I did ER overflow once, and I've like almost taken different travel assignments for ER overflow, but the ratios ranged from like 2 to 8 patients. Is that normal for the ER?
Wow. Well, it depends, I think, on what state you're in. I'm in California, and
so you got. Like,
am I supposed to tell people?
Yeah, you can.
And so we're 4 to 1 in the ER. And so, and then if you get an ICU patient or you get somebody that's critically ill, it becomes 1 to. It should become 1 to 1. It doesn't always become 1 to 1. You got your critical patients. Sometimes you'll get a second one, and then now they're loading up your other rooms. So it just depends. I've worked at a county institution, and now I work at a managed care institution. So it's a lot different now than it was then. There you just said, hey, I got an ICU. That's all I'm doing. And so somebody would cover your other patients. Okay. And here, now it's a little different.
Gotcha.
What do I say? So, but yeah, and you might be in one section of the ER that's like down towards the front of the ER, and then you've got a patient down at the far end of the ER that you're expected to keep an eye on and to get their vital signs and to do all sorts of stuff. And it's it can be difficult. It can be challenging, and I don't think there's always that understanding from the people that are above us.
Oh, so for sure.
Right. So something happens down at the other end of the department. It doesn't matter that you had 2 really sick patients, or what are you going to do? You can't split yourself in half. And when you're short-staffed, who are you going to ask to help? Because that's always the response, right? Well, why didn't you get help? Well, who am I supposed to help?
Yeah.
Because there's nobody there, right?
That's also, and it probably depends on, the ER also depends so heavily on like how beds are moving upstairs too.
Absolutely. And that is just a topic of conversation.
Did I hit the nail on the ER head?
That's a really sore spot, because I can, wow. Yeah. And most of the time we end up boarding patients in the ER. So, sometimes we'll have an ICU boarder downstairs too. So, and that makes it a lot challenging, because now you're trying to keep up with that patient, and
things are moving very quickly. And I'm sure you probably have, do you feel like you have less resources in the ER to deal with ICU patients than an ICU would? Or you feel like you have the same, or like, do you feel like you can adequately care for those like ICU boarders down there?
I think so. Now, absolutely. I think that we're able to, manage all the drips and manage, everything else that's going on. I think though the problem becomes when they start to get a little, they start to deteriorate, right? And they start to decompensate. And depending on the institution you're at, I came from a county institution where we had doctors and we had residents, and they did everything down there. And in the institution I'm at now, the ER docs can't even put in central lines. Yeah. So,
that's what I was thinking. You don't have the ICU team right there. You can't just run into their, room and be like, hey, you got to come take a look at this guy.
Yeah. Well, and that's another topic of conversation, is communicating with physicians, right? So, but yeah, I think we've got some great people in the ER. I think there's people that we're very capable of managing any ICU borders that we have, and deterioration and complication is one of those things that we don't always have the tools for, right? So, but we try to get them up, and I have to honestly say that ICU nurses and getting patients up to ICU is so much easier than trying to get somebody to a med surg floor.
Well, because I've been there too, where in the ICU, we understand the patient's really sick, you got to bring him up as soon as possible, and it doesn't really matter. Yeah. It matters what the assessment is, but it also doesn't matter because it's going to change, and we're going to, but on the floor, you're doing so many other things. I'm not to say there's frustration on both sides.
Let's hear it. Let me write it down. Let me put it on the list.
This is how we make the bridge, Raul. This is how we bridge the ER with acute care. No, but there's just, you have 4 or 5 people, and then you get an admission, and you're like, okay. I have these 2 things that I have to do, and this and this, but I will absolutely, I'll call you right back, and then something else happens, and you're like, right. I promise I'm trying to, yeah.
Well, what is that indicative of? What's that symptomatic of? Is that they're just as short-staffed as we are?
I think that there's so many needs. There's just so many, when you think of acute care, you think less acuity than the ICU, but I've come to find after doing both that it is hard to deal with 4 awake people because they all have needs. Everybody has needs. Everybody has to, if they're sick or weak and they have to go to the bathroom, that takes a good 15 minutes. If they have, pain or they don't have any pain meds on board, you have to communicate with the team and, get that pain under control. If they want to get up to the chair, it's something else, or you have to be a part of difficult conversations. You have to have enough time to sit at the bed and be empathetic for your patient. There's so many freaking things.
I'm not throwing shade anywhere on anybody, right? But I think we just need more people, right? We need more people to be able to do that, right? To be able to say, in order to kind of bring patients in that need to come in and to move things in the direction that they need to go to, right? And it's hard when you're trying to sit with that patient and listen to that patient. When in the back of your head, you're like, I got to do this. Okay, I'm already behind 2 hours on this, or you're just coming on, and the nurse before you didn't really do anything, right? Because let's face it, that happens too.
Well, right? and I shouldn't say, to the ER's frustration. There are nurses that just, sit on their butt and just let you call, and they want to, get all of their charting done and documentation and whatever. I'll call them back. They don't see the stress that you guys are under, where you're I need to move this patient because I have extra people that need this bed immediately.
Yeah. Yeah. Cause you got an MI that's coming in, or you got a stroke that's coming in, or, somebody hit their head, or Yeah. But, honestly, we all have to love each other. We all have to work with each other. And the thing is trying to make it work for the patient, the benefit of the patient, and also for our benefit as well, right? Because when you got somebody breathing down your neck that, hey, you got to get this patient upstairs, and every 5 minutes they're like, why isn't the patient upstairs? Why isn't the patient upstairs? Why isn't the patient upstairs? Then it's kind of hard, right? Because you got to go, why can't I send my patient? Why can't I send my patient? Why can't I send my patient? Right. But, you tend to figure it out, and I guess in the end it all kind of works, right? Or they just become boarders downstairs.
Yeah.
And
Or
one less new patient you're
we
gonna
end
get,
up,
right?
just rolling with it at the end.
Yeah, which is what we're good at doing, right?
Walk me through kind of a typical day in the ER, if you even can say any days are typical.
I think so. When I was at the county, days were more atypical because we saw everything there. But now being in a managed care organization, it's a little different because you tend to see a lot of the same things, right?
Okay. So, like what?
We'll start from the more mundane, where somebody's kid vomited once and I got to run to the emergency because it's an emergency. Or they had a fever, but they don't have a fever now, but they had a fever.
Yeah.
So there's that.
Okay.
And then you tend to get your geriatric patients that are coming in from the acute care, from the SNFs, right? That for some reason they were sick there, but when they get to you, there's absolutely nothing wrong with them, right? So we just work them up and then send them back. Then you get the people that indulge in extracurricular substances that kind of end up in the ER for various different reasons, and it all is kind of it's what everybody sees, right? So alcohol, marijuana, all the meth, all the other stuff, and then the psych patients. We get our psych patients coming in, and a lot of times there's some that just kind of come in, that are just we know them because they're there all the time.
Yeah.
Right.
Yeah.
So and then of course, you get your medical alerts that come in, strokes, MIs. We're not a trauma center, but occasionally we get people drive up that were in car accidents, and it's like my first thought is you're in the wrong place. You need to go down the road a little bit, right? So gunshots, stabbings, those all come to us too, and we're not a trauma center, so
Do they end up getting diverted, or do you stabilize them and then send them out?
I think legally we have to stabilize them and then send them out,
Yeah.
If I knew, if I would be, if I could, I'd be standing at the ambulance bay saying, no, you need to go down the street. Because, we're obviously not equipped for that kind of stuff.
Yeah. But, okay.
It's yeah. So typical day is I get to work always about 45 minutes, half an hour early. I sit out in my car, maybe eat something, and just kind of hang out, play a little game on my phone, kind of chill. I like to walk into work like 3 minutes. I have got it all timed out. 3 minutes before I'm supposed to be there, I leave my car, I walk in, and I punch in right on time. And I walk in nice, relaxed, not stressed out. So I can start my day like that. We get people running in there. Oh my gosh, I'm late. And that's not a good way to start your shift, because then you have to go to talk to somebody that's going to call you the F word or throw something at you, or try to hurt you, or just generally not be happy because they've been waiting there for 45 minutes and they think they've been there for 3 hours, right? So it's just it's a way for me to kind of be able to kind of approach my patients with a calmer sense of being. So
Is that generally how you, I expand on that for me, because I think that's one of the things that, I have feared about ER is those types of angry patients. How do you and how do your colleagues kind of work through those situations, or what's been effective for you?
Well, I think first of all is just kind of hearing them, right? What do you got to say? And then you try talking to them, and of course that never works because they're already angry. And you go through the whole training that they give you at the hospital on how to manage and do customer service, and sometimes that just doesn't work because and sometimes you just have to say, hey, look, stop. I'm not here for you to be swearing at me. I'm not here for you to be you can think about it, and then you just kind of turn around and you walk out of the room. You remove yourself from the situation. I mean, sometimes it's not that easy to turn around and walk out, right? Because they've pushed your buttons, or because that's what they're good at, right? So a lot of times you just gotta say, look, you know what? I'll talk to you in a little bit. right? And you come back a little bit later, or maybe they're angry because they're not getting that medication they wanted for pain, right? Instead they're getting the Tylenol, or the, excuse me, the non-branded pain relievers. But there's always that one that starts with the D, no,
Yeah, right.
So
Delata.
something, yeah. But that always takes my pain away really fast. Yeah.
Diphenhydramine.
Yeah,
That's what
that
it.
one, right?
Yes.
Yeah, exactly. So, once they find out they're getting that medication, they want, everything changes, right? Oh, I'm so sorry, I swore at you. I'm so sorry at this, and it's like, yeah, we probably should have thought of that before we started slinging words, right?
Yeah. I know. I mean, I think honestly, that's one of the patient populations that I'm not good at, is ones that it's drug seekers. It's like the ones that know how to manipulate people. And I think that's such a hard population to navigate for a lot of nurses, because you're here to care for others. You're here to be in that presence. And a lot of times you're there to serve. Like that's kind of a mentality of nursing sometimes. I had that mentality for a long time, and I've no longer have that mentality. But but it was hard because you get, taken advantage of. And so that's always been a really hard patient population for me. And I'm always interested in how people navigate those patients.
Once you've seen a few of them, you kind of know who they are, right? I mean, and you know what their game is. And so what I'll do with that is I'll communicate it to the doctor. And there's, of course, other ways that you can tell physiologically what's going on with them. There's always something in the room that kind of tells us what's going on, right? So, I think that, we're not the police, right? So, it's ultimately not our decision as nurses whether this patient gets his medication or not, right? So, and it's ultimately the doctor's responsibility. And at some point, these patients get figured out, whether it's that day that they're with you, or whether it's the next week they come back, or the 30th time that they come back, somebody always figures it out, right?
Yeah, that's very true.
So what do? There's an order that's written for your patient, and and obviously if there's some other confounding thing going on, or something that's kind of detrimental, or what's the word I'm looking for? Gosh, I'm at a loss for words. First time I've ever been at a loss of words.
Like an appropriate situation where they would be getting pain medicine.
Yeah, maybe. Absolutely. Yeah. Or there's something that, hey, we can't give it to you because you've got another medication on board, or and that's a little different, right? But it's really not our decisions, and it's not up to us to be judgmental about, what their motivators are, right? And now I say that, but I'm human just like everybody else, right? So
I think that's an important thing to note, is like, you can only do so much. You can only say what's ordered. You can, you only have the ability to carry out the orders, and you can communicate to the team what the concerns are, and, your assessment findings, obviously, and come up with a good treatment plan. And sometimes that's not what the patient wants, but, that's the best that you can do, sometimes.
And I think, so long as they don't get upset with you and start swinging at you or whatever, there's always ways to manage that, right? I mean, and working at a county hospital is just a completely different animal, and just the things that you see, and how the acuity of mental health patients that you see. We're punching bags sometimes, right? So
I'm sure that probably the highest amount of, violence a lot of times is psych units and ER.
Yeah.
I think, just because of the patient populations that you see. I mean, you come in, any walk of life comes in to both, places.
Yeah. I'll share a little bit about with you. I've been headbutted, been kicked in the chest, punched in the chest. I've had a patient kind of take me down, or we both gone down. It's kind of crazy sometimes the things that you don't see, in day-to-day life, right?
Yeah.
So
Right.
yeah,
It can be,
it's
that's wild. It can be in
yeah.
a really wild place to work.
I had I'll share a little story with you. I had a little she was, I guess she's 98 pounds probably. Um, Came in, she was having she was either on some sort of substance or having a breakdown of some sort, and we had her restrained to the bed, and I'm talking to her, and she just kind of propped herself up and kind of cocked her head back, and she headbutted me. Yeah. And as I see her head coming towards me, I kind of pull my head back, and she managed to kind of knock me right here, and then kind of knock my glasses
It's
down,
not
and
funny.
I kind of just went back, and I was standing under a camera, so
Mm.
of course, there was police there. I ended up pressing charges,
Mm.
and which is something that we as nurses need to do,
Yeah.
right? Our hospitals need to support us as well.
Yeah.
And as far as I'm concerned, there should be signs all over the hospital, any hospital, all over all hospitals that say you will not abuse our staff,
Yeah.
right? And if you do, then you have no business being here.
Yeah. That's so
So
true. I mean, it's so true. I think there's, and it's all like subjective or like emotional, like barriers that prevent us from wanting to press chart. Like there's been a couple times where like, a patient tried to kick a pregnant woman in the stomach. I remember like there was one patient from an acute care floor, and it was like, what if he actually had done that? I mean, he was a traumatic brain injury, but are you going to, I mean, at what point is your life more important? I think that people should still be held accountable for some of those things.
Absolutely.
And especially obviously in the ER, I mean, if they're in their like right mind and it's like, this is just not the place. People have to show respect, and you have to be supported by everybody involved.
Yeah, everybody from the from the bottom to the top, right? And we don't see that though, Unfortunately, we don't see that. We don't have administrators coming down, hey, you don't do that to my nurse, or you don't do that to our nurses. There's no sign that says, hey, you know what, if you're rude or offensive or you assault any of my nurses, guess what? You get to go and you don't ever get to come back.
Yeah.
Right?
Yeah, it's absolutely there should be more at least signs. I mean, signs are just the easiest, most passive way to like send that message.
Right. But then is that customer service telling your patients that they can't assault your staff?
You would think that it's implied. Like maybe they just don't have them up because they think that that's in, like if at a hotel, like, there are no signs saying like, don't abuse the housekeeping hotel concierge service.
But there should be, right?
But there should be. If there's,
Mm-hmm.
I know people are, especially in this, I mean, and a hotel is not like the high stress, high stakes environment that is the hospital, especially because we have like so many accounts of nurse abuse. I think that it would be so appropriate. I wonder if anybody's listening and you do have like signs or like a good way that your hospital deals with, nurse abuse or preventing that, DM me, because I would love to hear, what you guys have to say about that.
Yeah, that would be awesome to see if that in fact is the case. And
somewhere,
quite honestly, well, I think more needs to be done. First of all, to take better care of us as nurses, right? Yeah. I mean, we get paid for the job that we do. Depending on where you are, it is what it is. But it's not enough. Yeah. Right. It's not enough to be kicked, punched, to be screamed at, to be spit at. It's just not enough, right? Some can argue that if you can't take it, well, you're in the wrong place, right? But that's never the right attitude.
You're gonna lose everybody before that's,
Yeah. So there should be steps taken to protect us and to ensure that there's not only positive communication from our end, but also positive communication from patients.
Yeah.
And you can argue they're in a high stress situation, they're sick, they're whatever, but I think if anything, that should bring you closer to the person that's trying to help you.
Yeah. Absolutely. I want to flip this on its head a little bit and just talk about, are there any, what aspects of the ER have kept you in the ER, you think? Or is there enjoyable, like, you know, what is the most kind of fulfilling things for you in the ER setting?
Wow, that's a great question, actually. I think the most enjoyable thing for me versus being like on a med surg floor, which I love all you med surg nurses, but you won't find me working with you up there.
That's understand. You know, everybody has their niche.
Yeah, everybody has their niche, right? I think that, you know, well, let me back up a little bit. I think med surg nurses carry a huge responsibility because, you know, people are constantly trying to take them out of the routine to give them new patients, and that's not easy, right? And down in the ER, we feel the same thing when you know we get all our patients situated, get somebody discharged, and you turn around and there's somebody in your room that nobody told you about, right?
So frustrating.
So I mean, that kind of stuff happens all the time. So I can't imagine what it's like for them, and you know, they're the ones that make sure the patients get, you know, throughout their hospital stay, you know, have an uneventful hospital stay, right? So much love to all of you med surg and telemetry nurses and ortho nurses and other thing that you guys do. Just help us get more beds. No,
yeah, just get the patients up there.
I think that seeing new things every day for me is one of the things that keeps me coming back. New things every hour, right? To see constantly changing. The environment changes so constantly with the type of patients that you get. And that you can make such an immediate, profound impact in somebody's life, right?
That's very true. So, I you know, if you go into nursing to be in on the action, like acute care nursing is probably not it. Because you'll be like waiting for that action, you know, but the ER, it's like, okay, somebody said they're coming in and they seized 30 minutes ago. Oh, they're seizing now. Like, you know, you're right there when the acuity is highest that you're, you know, that is amazing.
I would argue though that wanting to be there for all the cool stuff, all the you know, the MIs, the traumas, whatever. I mean, it's an important part of what we do, but you have to remember that there's always somebody there that trauma that you're getting excited for, somebody is suffering, right? Is that, you know, that the high energy, that high you know, the high what is it?
High stakes
hormone that we
adrenaline.
Yeah, that adrenaline rush thing. There's always somebody there that suffers it at that's coming in, that's suffering, that we get excited to be able to be doing. Does that make sense?
That's a hard, I mean, it's a hard balance for sure. It's the same in the ICU as well. I mean, codes are just so traumatic, and you have to be so on in that moment, and thinking clearly. But if you have family there as well, you have to also, like, normally, at least where I work, we normally try to have one person that's with the family and explaining what's going on so they can focus on it's like that's their role in the code.
Yeah, I think that's very important. I think that's something that's very needed. Yeah,
because it's hard to do both. It's hard to hold space for both in that high stakes, high stress moment.
Yeah. I think it's an important role to have somebody talk to the family and let them know what's going on, and you know, I don't know to what extent a family member wants to see, you know, their loved one getting compressed and going through all that stuff, and but it is what it is, and I think I think there's more to our job than just doing the high stakes, high adrenaline stuff, and I think it's important that if you are going to be an ER nurse, if you are now, that there's always somebody there that's this adrenaline that we search for, that we look out. There's somebody that's suffering on the other end of that, and so. To a certain extent, I think we need to honor those patients by giving them the best that we can, and looking at maybe trying to help them either, you know, continue on or even help them, you know, take their final steps, right?
I think it just goes back to that quote from Jade Simmons, you know, that we have the ability to shift the atmosphere. You know, it's just something to remember.
Yeah. And I'm going to tell you that my experience with codes is a lot different at the county than it is in managed care. And I don't, quite honestly, it's probably better. I think I liked how they were run more when I worked for the county, you know. I think everybody had their purpose and everybody was in there and there weren't a lot of people and it wasn't a show of sorts, and so which it can turn into.
Yeah.
You know, especially when you've got firefighters and police and other staff and
Yeah. Oh, I didn't think about that either. What do you think are if you had to name some characteristics that make up a strong ER nurse for somebody that's maybe considering ER, making the change, or somebody in nursing school that's considering ER? What are some strong characteristics?
Wow. You know, I think it's a little different for me since I started out in the ER many years ago, and you know, all of those things all of the hard lessons that I had to learn, I kind of figured them out. You know, and that was as a tech, but also, you know, observing other nurses and how they did their job, serving nurses at the time and how they did their job and how they went about it, and, you know, the level of professionalism but I think that, you know, you need to be able to ground yourself. That's the biggest thing, because things are going to happen around you and you just need to be able to ground yourself and be able to step up to what it is that you need to do.
Okay.
Yeah, I mean, those are the two basic things. I think being able to think quickly on your feet as well is another one. Being able to read your patients, being able to read the people around you is one of those things, because you can sometimes sense more or less when a patient's going to go from being okay to being not so okay, which can sometimes happen right away. And
I feel like you can't assume in the ER. You can't just assume.
Yeah, you can't trust your patients in the ER, you know, whether they look good, because sometimes they won't be looking good this minute you turn your back on them, right? So, you know, and I mean that obviously jokingly, but yeah, you got to keep an eye on your patients, and you got to you should be prepared to be on your feet all the time, constantly checking on your patients, which you and I both know that that's not what happens, right? We know that, you know, some people just do the bare minimum and they just kind of hang out and you know, and it sucks because you know, if you're one of these people that are constantly checking on your patients, you know, rounding on your patients like we're supposed to, making sure that they're okay, and all you see are people just kind of sitting down hanging out the whole shift, it's not, you know, it's not fair to their patients.
Well, right? And then those are the patients that are going to like unexpectedly, you know, code because you're not, you know, they're not being checked on, they're not being monitored. Whereas like, you know, the person that's constantly checking on their patients, you're going to know your patients so much more. The continuity of care is going to be better. You know?
Yeah. It's important. But I'll say the one thing I think just in general that I really kind of wanted to touch on with you is how we train nurses, right? How we train nurses that are coming onto the floors, and, you know, and to what extent they're given the appropriate or proper training. You know, I don't think there's enough training. I mean, especially with new nurses that are coming on. Yeah. You know, I think sometimes they're just thrown to the wolves, and if they can hack that, then they're going to be okay. Which it's never good, because that doesn't produce good nurses, right?
That really happened a lot over the last couple of years. I think people are just, you know, we were short staffed and they were like, you're going to take an assignment today, you know, hopefully you had enough, you know, and that just breeds nurses that aren't confident in themselves and, you know.
Right. That aren't competent either, right? Isn't it funny how we went from everybody wanting to have their nurses have 2 years experience before they can apply for a job to all of a sudden now, hey, let's give everybody a job, right? I think, you know, I think if anything during the COVID, while we were going through COVID, is I think we should have brought on those new nurses. I think we should have started training them then, right? Because now they'll have that experience of what it's like working through a pandemic, how it is to work with seriously ill patients, right? And then they'll go on to be able to then go on and train other nurses and teach them and show them, you know, and kind of groom them to be able to get through these events that happen like that.
I think that it is important more now than ever. I mean, because retrospectively, we can't do anything about the past. We can only do things about what's happening now, is to support our new nurses more than ever and just check on them. Just, you know, make sure if they check on their patients, see how they're doing, like let them, you know, just walk through like their plan for the patients for the day, or like, you know, this is going on with my patient. I don't know if I should do this and this, like give them advice, like just, you know, check in intent, like have intention to check on the new nurses on your unit, because you just absolutely don't know, like we're not new nurses anymore, you know, and you don't know the kind of, you know, guidance or lack of guidance that they've been given because of the resources and the experiences we had over the last 2 years. So, you know, supporting our young is very, very important nowadays.
I think that's absolutely correct. I think we need to support them. I think that if you're training, you know, if you're precepting a nurse, don't do everything for them, because they don't learn that way, right? Mm-hmm. You got to let them get out there and let them stumble a little bit to kind of figure things out, and give them the opportunity to figure things out. And if they can't, show them how to figure things out, right? Because if you're doing everything for your preceptee, you know, when it comes time, 3-4 weeks or however long and they're cut out and they're left out on their own, then what, right? They're starting from zero again. So.
Very true. Well, I think that's where we're going to end our episode today. Raul, thank you so much for coming on and talking to me about ER and NTI. And this was a really great conversation.
Maggie, it was such a pleasure. And if you'll allow me to kind of plug our little group here for next year.
Absolutely.
If you are going to NTI next year and you're traveling by yourself, there's no reason to kind of experience the conference by yourself. Look for the NTI 2023 Solo Travelers group. We'll be on Facebook. I'll try to get something up on the forums. I'll maybe even tweet. I tweeted for my first time at NTI 2023, so I'm a big social media person now. And for those of you that are going to ENA 2022, look for the same group. It'll probably be on Facebook. It'll be ENA 2022 Solo Travelers, something to that effect. Or, you know, I'll probably tweet. I'll try to get ENA to help out with that as well. But really, there's no reason for you to be experiencing. Well, first of all, there's no reason for you to be afraid to go to a conference by yourself, or travel anywhere for that matter, because, you know, it's that fear of doing these things that keeps us from growing.
Yeah.
So come be in community with fellow nurses, have an amazing time to chat and meet new people, and have some amazing dinners and just an amazing experience. So Maggie, thank you so much, and thank you to your audience for being so gracious enough to listen to me.
Yes, thank you so much. I look forward to future conferences with you too.
I do too. I'm looking forward to that.
All right. We'll talk to you later. Bye. That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.